congressional Republicans are in a bind. They really want tax cuts, but that could put America much deeper into debt unless they can also cut federal spending. Republican lawmakers will need to slash hundreds of billions of dollars, and they are targeting health care for a lot of those savings. Patient advocates and medical groups are already sounding alarms. The budget fight ahead is going to be fierce.
Disability rights advocates rallied at the State House in Trenton earlier today, speaking out against potential cuts to Medicaid.
It is mathematically impossible to cut $880 billion from that committee without touching Medicare or Medicaid.
Would you mind telling your colleagues in Washington that when they're burning down this house, there's people still inside? My kid is inside.
There is one proposal, though, that seems almost easy. Reduce the inflated payments from Medicare that go to clinics owned by hospitals. Republicans and Democrats like it. The payment could deliver real savings, $150 billion over a decade. The problem, rural hospitals, many in Republican districts, could take a financial hit that might put some out of business. Today, why this proposal for savings that looks so simple isn't. From the studio at the Leonard Davis Institute at the University of Pennsylvania, I'm Dan Gorenstein. This is Tradeoffs. We're joined by Tradeoffs producer Melanie Evans, who is here to dive into this popular option Republicans have to cut spending. Melanie, hello.
Hi, Dan.
So usually when lawmakers want to cut spending, it's pretty unpopular. But this option to cut inflated payments from Medicare, which has its own wonky name, site neutral, is super popular. Why?
Well, let me give you the current state of play. Medicare pays more to hospital-owned clinics than it pays to clinics not owned by hospitals.
And I mean, it can be a lot more, right? Like sometimes double?
It can be even higher than that. For some chemotherapy, it's 300%. Allergy tests, 400%. Get this, Dan, $719 on average at hospital clinics. For an allergy test everywhere else, it's $176.
Yeah, and I mean, the fact is that the allergy test is no different at the hospital clinic, so why pay 400% more?
Exactly. So at its most basic, the Republican proposal would start paying all clinics the same, whether they're owned by a hospital or not. And depending on the scope of the cut, this would save Medicare anywhere from $5.6 billion to $157 billion over the next decade.
This is why so many people love this idea.
This is why so many people love this idea. In fact, it has bipartisan support. But with Republicans in control of Congress, Democrats are effectively sidelined. There is one group that's opposed, though. Hospitals.
No surprise.
Right. Hospitals say they need higher prices for Medicare to cover their higher costs. They have expensive technology, so many regulations, their doors are always open, and doctors and nurses who are highly paid and highly skilled are working around the clock.
Sure, all that overhead is costly and necessary to take care of people who are incredibly sick, legitimately, patients in the emergency room and the intensive care unit. But an allergy test, Melanie, I mean, that overhead seems unnecessary.
And that's the issue. There's a lot of medical care that hospitals offer that's pretty routine. So hospitals now own clinics where patients go for checkups and common procedures. Think of colonoscopies and mammograms and heart tests. That's why proposals for site neutral, to use the very wonky name, are so popular. Because many lawmakers object to paying for hospital overhead for routine medical care.
And they figure most hospitals can take the hit.
Well, they are concerned about rural hospitals. These rural hospitals have the same overhead, but they typically make less money.
And I guess that's why lots of rural hospitals, right, are watching Congress very, very closely right now, which is tough for Republicans because they represent a lot of these rural hospitals. And anytime there's a proposal to cut their Medicare funding, rural hospitals start warning they might have to cut back on care, or worse, if they lose money.
That's right.
Melanie and I wanted to understand what it means to run a rural hospital on a tight budget, so we called up Tim Rye.
I'm the Chief Strategic Development Officer for Peterson Health in Kerrville, Texas. We're a 124-bed hospital and, like I said, right in the heart of the Texas Hill Country.
Kerrville is home to about 24,000 people. The hospital is a big deal in town, and people let you know that, Tim says, like when he's at church or Peterson's doctors and nurses go shopping.
Kerrville's the kind of place you know you're going to spend an extra 15, 20 minutes in the grocery store because some little old lady that you saw in the clinic's going to want to hug your neck and tell you how great you are.
Tim calls Kerrville a unicorn. It has most things that you'd want, and everything else is a quick 45-minute trip to San Antonio.
We did not offer 24/7 heart attack coverage. We were doing basic outpatient cardiac procedures.
Rural hospitals have less wiggle room in their budgets, so decisions to expand or close services are risky. A misstep can take a bite out of their finances. About 8 years ago, Peterson decided to invest in more cardiac care. They saw it as the proverbial win-win, a way to increase revenue and add an important service for people in a town Tim says is nicknamed God's waiting room.
Over 30% of the population is over the age of 60. And in the state, I think it's somewhere around 14%. So my wife has become quite the estate sale junkie. It's a town very rich for that.
Offering more cardiac care, Tim says, has mattered.
A lady, it was on her birthday, was making a cake and started having a heart attack. And from the time they called EMS to the time they had surgery was like 40 some odd minutes. Helicopters are great, ambulances are great, but distance and time, you know what they say, time is muscle when it comes to that stuff.
Peterson Health's ability to offer any new services inside the hospital or across its clinics depends on its overall financial strength, Tim says. Any hit to the budget can weaken Peterson's finances. Like during the pandemic, when money got tight, Peterson had to shelve plans to recruit a second heart specialist. Now, it's site neutral that's threatening to squeeze Peterson's budget.
It's a killer. We'll have to move from growth, not just in what we're currently doing, but the things we're not doing that we'd like to do.
So, Melanie, talking to Tim gives us a pretty clear sense of this economic edge that they're feeling and walking all the time.
Dan, Peterson looks like a bunch of the 900 rural hospitals that could need some financial help if site neutral goes forward. It's on its own, with no big health system behind it to recruit doctors or buy equipment or to bail it out in a bad year. Also, Medicare is the hospital's biggest customer. And right now, congressional Republicans are debating whether rural hospitals need protection from site neutral.
That would mean Medicare continuing to pay the inflated prices to them.
That is one of the options, yes. Dan, this decision to exempt rural hospitals, it's a big one for lawmakers. There are policy experts who think an exemption would be a huge mistake.
When we come back, producer Melanie Evans runs some numbers on rural hospital finances, and we get into options that the Republicans are exploring for rural hospitals and site-neutral policy. Welcome back. As we talked about at the top of the show, Republicans are on a cost-cutting mission. They're out to slash as much federal spending as possible to make room in the budget for tax cuts that they want. One popular possible target is a move for Medicare to pay hospitals less for care in the clinics and outpatient centers that they own, these so-called site-neutral payments. But many rural hospitals rely on this revenue. This lands Republicans in the middle of a decades-long debate over the survival of rural hospitals. To move forward, policymakers are considering a few paths. Producer Melanie Evans is back to talk to us through the range of proposals Republicans are considering. Melanie, Hello.
Hey, Dan.
So if you are a Republican in the House or the Senate, to afford the party's tax cut package, you need a ton of money. The more hospitals you shield from a site-neutral proposal, the less money for your tax cuts. But if Republicans push ahead without aid for these distressed hospitals, some may close.
Correct. So how do Republicans skate that line? I spoke with Carrie Cochran-McClain. She's at the National Rural Health Association. She is arguing for a broad exemption for rural hospitals.
We've seen over 190 rural hospitals close their doors or discontinue inpatient services in the last 15 years. And a movement towards site neutrality, we think, would close, a significant number of facilities across the country.
So here's the thing. A broad exemption, Dan, would apply to about 900 hospitals. But I know from all the reporting I've done on hospitals for about 20 years, the financial picture at hospitals can look pretty different from one to the next. So I did something I love to do, dig into data.
What data did you dig into, Melanie Evans?
Dan, I looked at two indicators of financial strength. The first is credit ratings. This is just like a personal credit score, but for companies. Strong finances typically mean a great credit rating. I was curious, how many rural hospitals are owned by a wealthy organization with great credit?
Yeah, what's the answer? How many are there?
There are nearly 150, spread across 36 states. You probably know some of these owners. Mayo Clinic, Kaiser Permanente, Intermountain Health.
It's like the Mount Rushmore, Melanie, of hospital systems.
Dan, these systems have some of the highest credit ratings from two agencies, Moody's Investors Service and S&P Global Ratings. S&P shows the median savings for their top-tier hospital systems is between $3 billion and $9 billion. This is cash that the hospital systems typically hold and invest, which also makes them more money.
Okay, so presumably these 150 rurals are the ones best positioned to withstand a financial hit.
Yes. The average operating margin for these 150 is 3.4%. For the full 900 rural hospitals we looked at, the average is less than 1%. It's basically break even.
Wow, that's pretty different, Melanie. So that's credit ratings. What's the other measure that you looked at?
Market power. Whether rural hospitals face any competition. When hospitals lack competitors, it's easier to raise prices. Higher prices, more revenue.
Sure, but of course, right, some rural hospitals in remote regions of the country don't have much competition because they are in remote regions of the country.
That's absolutely true. But I looked at research from Yale and the University of Wisconsin, and I found two things. One, more than 2/3 of the hospitals owned by these wealthy systems have monopolies. And two, some of these hospitals are in remote corners of the country, but many are not.
I think what you're saying here, Melanie, is that not all rural hospitals are created equal. And at least based on your analysis, there are some that certainly look like they can afford to lose these bigger Medicare payments.
Yep, that's right.
Now, Republicans in Congress have a few paths that they could take for site-neutral proposals. The options would expose rural hospitals to Medicare cuts to varying degrees. Melanie, what are the options on the table?
Let's start with one point I heard over and over from health economists and policy experts. They think Medicare continuing to overpay for outpatient care is a terrible way to keep rural hospitals open. Here's Loren Adler of the Brookings Institution.
In my eyes, there are two separate issues here that aren't actually really that intertwined. So, right, there is the issue that Medicare pays too much for services. And then separately, there is the issue that it is often difficult to make a rural or safety net hospital profitable.
Loren has spent a lot of time studying Medicare and hospital markets. He really wants Medicare to stop these payments. The thing to remember is that some Medicare patients have to pay up to 20% of their own bills. So when Medicare keeps paying hospitals more, so do patients.
Right. So the status quo means patients keep spending more of their own money on medical care.
A lot more, Dan. And another problem with the status quo? Consolidation. As we talked about earlier, Dan, Medicare pays more to clinics owned by hospitals.
Yeah, like sometimes 300, 400% more.
Right. And that kind of difference has given hospitals a big reason to buy up physician practices.
I mean, it is no-brainer, right? Let's assume that you have a stand, right, next to a street and you're selling something. And I tell you, just keep and move your stand across the street on the other side and you can charge people 3 times more. What would you do?
That's Ali Moghtaderi. He's a health economist at George Washington University. Ali and his colleagues published a paper that offers some of the strongest evidence I've seen that this policy drives up consolidation. They found that over about 20 years, Medicare continued to pay hospital-owned facilities more for heart disease testing, and the percentage of cardiologists working for hospitals climbed from 20% to 60%, Dan.
Because hospitals could charge so much more per test, they figured it was worth buying up the practice. And as a result, these hospitals went on like a spending spree, scooping up every independently owned cardiology practice in the land.
Indeed. And this was bad for Medicare. Ali and his colleagues calculated it added about $600 million a year to Medicare spending. But more than that, when hospitals buy up the competition, there are fewer options for patients to shop around, and that is bad for everybody.
It creates market concentration, it creates market power, and it just increases the overall cost because the prices increases as a result of that. And then there is not much evidence that there is any downstream benefit in terms of gain in efficiency or gain in the quality of care.
We know from lots of research that consolidation leads to higher prices that we all pay. For me, Dan, this study is the connective tissue between why site-neutral matters for Medicare and why the policy also matters for everyone else who pays for healthcare. To underscore this point, this is why so many employers are lobbying so hard for site-neutral. The more hospitals buy up doctors, the more market power they have to raise prices for private insurance.
Okay, so the status quo sounds pretty costly for patients, Melanie. But the upside, at least, I guess, is there's less of a threat to vulnerable rural hospitals, which has got to mean something to Republican lawmakers in Congress because, again, they are representing lots of these places.
Correct. A second option, Dan, is that Congress lowers these Medicare payment rates for most hospitals but exempts rural hospitals. But a full exemption would leave billions on the table as Republicans are looking for every last penny, if those are still in circulation.
It's hard, Melanie, to imagine Republicans leaving any money on the table right now.
Yeah, that's right. Republicans are looking for as much as $880 billion from healthcare for their tax package. That is tough math, and it's unclear whether Congress will give rural hospitals a pass.
Okay, so, Melanie, if full exemption is unlikely, what's likely or more likely?
That brings us to our third option, Dan, a kind of targeted approach to help rural hospitals with more financial aid. Senators Bill Cassidy, a Republican, and Maggie Hassan, a Democrat, put out a framework for their proposal. Dean Clancy at Americans for Prosperity, which is a conservative group, told me the framework won endorsement from across the political spectrum.
I mean, you got the AFP on the right and Families USA on the left. We don't agree on very much, but on this one we do.
I am trying to imagine this group's WhatsApp chat.
Wait, do they have one?
No, they don't.
Okay. So, look, what does this very popular plan involve?
There are many medical services that are frequently done in a doctor's office. Chemotherapy, scans. Hassan and Cassidy's proposal would require Medicare to pay hospital-owned clinics the same as everyone else for these services. This is also how Medicare's own advisors identified medical care that can be safely done away from hospitals.
Right. Hospitals have tried to justify the higher prices at their clinics because if there's a problem, patients are plugged into the hospital. But since these services can be done safely outside a hospital, there's no reason to pay for that overhead.
Yes, and there's more to Cassidy and Hassan's proposal. They want Medicare to pay the same for every service for all off-campus clinics.
Sure. Let's define off-campus clinics quickly. Hospitals have some outpatient centers inside their walls or on campus, but many also have clinics and imaging and surgery centers miles away. These are off campus.
Exactly.
So where does this targeting come in? By that, I mean, how would the plan get rural hospitals some money?
So Hassan and Cassidy are proposing to subsidize struggling rural hospitals and pay them to provide certain services. Think about obstetrics. Dan, the idea is to incentivize hospitals to offer critical services that can sometimes lose money and push rural hospitals into innovative ways to charge for their services. But if Congress goes down this path, Dan, you can expect a fight.
Makes sense. I mean, some kind of targeted approach means Congress is going to devise a formula to decide who needs help and who does not. There will be winners and there will be losers.
And a big part of that fight will be how to decide which hospitals can afford to take a hit and which ones need more help. The analysis we did is one way to think about winners and losers, right? We looked at hospitals' financial and market strength.
Right. Hospitals' credit rating. And again, a strong rating typically means they're making a profit and have a bunch of savings. We also looked at which hospitals have more power to raise prices from what looks more like a monopoly.
When I talked with health policy experts, they said it's harder to justify subsidizing hospitals with the best credit ratings and a lot of market power. Loren Adler at Brookings summed it up well.
There are a number of rural hospitals that look very much like what you would consider a suburban hospital in an area that is not particularly low income and are doing just fine.
Now, Carrie Cochran-McClain at the National Rural Health Association told me she recognizes that some rural hospitals do have more resources.
We acknowledge all you have to do, to your point, is look at kind of income earning statements for some of the large hospital systems and see that there are definitely facilities in this country that are doing quite well, right? And then there are facilities like a lot of the ones we work with that are barely keeping their doors open.
But there's a nuance she's worried lawmakers may forget. She says it's possible that wealthy owners may just hit a point where they decide a rural hospital in their portfolio is losing too much money.
It's not just a guarantee that if a system has profit and success other places, that they would pull from that to invest in the rural, or that rural eventually wouldn't become such a loss leader that they would be, again, financially forced to close it.
Dan, Carrie laid out for me the basic economic problem of many rural hospitals. They often take care of fewer patients. Many of those patients often have public insurance, which pays less than other health plans. But they still have all the expensive overhead of running a hospital.
And Melanie, we've reported on this before. These arguments seem reasonable.
Yes, look, there is a lot of concern for rural hospitals. We heard it at the top of the show. But Republicans are rushing this plan to slash federal spending. And to reach their savings targets, they are going to have to make cuts to Medicare or Medicaid. That crunch is an opening for proponents of Medicare payment reforms.
But that doesn't leave much room for debate on safeguards for vulnerable hospitals.
Not much. We should know soon where Republicans land.
Melanie, thank you so much for your reporting and for all of that number crunching. That was great.
You are welcome, Dan.
Back in Kerrville, Texas, at Peterson Health, Tim Rye projects a $1 million hit from a possible Republican site-neutral payment proposal. It sounds small for a hospital with more than $200 million in annual revenue. It's not.
You just took our margin, right? So a good year, our margin might be $1 or $2 million, right? And so you impacted my ability to invest in capital equipment and all those types of things.
Peterson faces budget pressures from Medicare in other ways, too. Revenue has declined as more Medicare patients switch to the managed care option called Medicare Advantage, he says. When budgets get too tight, hospitals often close services. Tim says he has an idea of where Peterson would look.
I think I know, but I'm just afraid of the answer, and it's probably something like OB. That is very Medicaid heavy and already a loss. I don't know that I could look people in the eye if we had to make a decision like that and say, this is what we had to do to our community.
Tim estimates the hospital delivers about 500 babies a year. He says people in town take pride in the hospital. It's part of what makes the community feel whole. But he's worried less Medicare money will force his hand.
Something's got to give. You can't keep squeezing, especially rural hospitals, and expect that you're going to have a lot of them left if you keep cutting Medicare.
Tim says that's the message he has for the hospital's congressman, Republican Chip Roy. It's the message lots of rural hospitals are sending to their members of Congress. I'm Dan Gorenstein. This is Tradeoffs. Jails and prisons must provide medical care for the people they incarcerate. But when a person gets out, all that goes away.
People lose their care, they lose their medications, and they get sick. They go to the hospital, and too often they die.
To keep people healthy and alive, policymakers are turning to a previously forbidden solution: paying for Medicaid coverage before people leave jail and prison. Next time on Tradeoffs.
If you enjoyed today's episode of Tradeoffs, don't keep it to yourself. Tell someone else about it. Friend, colleague, family member. Better still, leave a rating or a review wherever you subscribe to us, the NPR app, Apple Podcasts, Spotify, wherever. The Tradeoffs team is producers Melanie Evans and Ryan Levy, editor Deborah Franklin, executive director Jessica Silverman, marketing director Catherine Dougal, with help from Kate Seepy, Cedric Wilson, and Colleen Schenk, sound designer Andrew Perella, executive editor Dan Gorenstein, and senior producer Leslie Walker. The Tradeoffs theme song was composed by Ty Sitterman, with additional music this episode from Blue Dot Sessions and Epidemic Sound. Tradeoffs coverage of Medicare sustainability is supported in part by Arnold Ventures. Additional thanks to Stuart Craig, Zach Cooper, Ted O'Con, Sean Greminger, Sophia Tripoli, and Brian Mittendorf. Thanks also to all our listeners who helped to support our work, including Daniel Polsky, Chris Severn, Tracy Burstein, and Laura Hart. Our media partner is Side Effects Public Media, based at WFYI. Tradeoffs is supported by the Robert Wood Johnson Foundation, Arnold Ventures, the Gordon and Betty Moore Foundation, the Sozoze Foundation, Just Trust, West Health, the California Healthcare Foundation, the Foundation for Opioid Response Efforts, and the Leonard Davis Institute at the University of Pennsylvania. Our financial supporters are not involved in any decisions about our journalism. The views expressed in this episode are those of the individuals and not those of Tradeoffs staff, advisors, or funders.